All right. Today we get to talk about pain. Yay. Temperature and pain. You guys are going to have to bear with me because I had private psych at 9:30, and then I had I had to run 2 job interviews at 11 and at noon. And now I'm here with you. So it's been a busy day since 9:30, and I'm worried about losing my voice. So bear with me. We're going to talk about temperature and pain today. Any questions on the somatosensory system sort of in general from Tuesday? Yes?
The sensory elements, those aren't actual neurons, they're like bundles of other cells that like count the neuron?
Yes, the receptor structures the neurons are embedded, the actual sensory neurons are embedded in things. Yes. All right, so you can do your whole, bottom-up signaling charts and everything for what we did last time, right? Receptor, transduction, pathway, CNS areas, perceptions. Good. Yes?
For the lab report, do we do outside research, or is it like the other one where we can use like the PowerPoints and stuff?
I don't think I provided an outside source, so you don't have to go find it. Okay. And hopefully today, we talk about thermal detection also will help with that. So, temperature perception. The last group of somatosensory receptors that we haven't talked about are free nerve endings, right? So we talked about the mechanoreceptors extensively, and then we talked about proteoreceptors, which is particularly for kinesthesis, right? But the free nerve endings are going to be the neurons that are detecting changes in temperature. And that's what's really important, is to understand that cold receptors are responding to decreases in temperature. So if you're walking around and it's summertime and it's 100 degrees outside and you walk into a building and it's 80 degrees in the building, right? Those cold receptors are going to fire. You're going to feel that change in temperature, even though it's not really cold, right? Even though you wouldn't describe 80 degrees as being cold, that's still warm. But they're going to fire because the temperature decreases. Cold receptors are closer to the skin, and warm receptors are a little bit deeper in the dermis layer. Warm receptors are the opposite, right? Anytime we experience an increase in temperature, that's going to be warm receptors. Now, if you, all right, we'll do an exercise. So put your hands on the table, right? And I want you to feel, what temperature does the table feel? Just get that in your head, right? Now, feel the carpet. What temperature does the carpet feel? All right, do they feel like they're different temperatures? Yeah? What, describe your perceptions. The table feels colder than the carpet. Now, can that be? I mean, it's been sitting in this room together all day, same temperature, right? One's not heated than the other. Right? So this is what we call thermal conductivity. Right? And so the table, the surface of the table is highly conductive, and it actually is pulling heat out of your hand. When you put your hand on the table, it's pulling heat out of your hand. So what does that cause it?
Your hand.
A decrease in temperature, right? It's stimulating those cold receptors, right? And the carpet is not very thermal conductivity, it has very low thermal conductivity. And so it has a warmer feeling to it, right? It's the difference between like stepping on your cement floor in your dorm room or stepping on a carpet in your dorm room, right? It has a different thermal conductivity, even though it's technically all room temperature, the same temperature. How that heat gets pulled in or away from our skin creates or activates those receptors, right? Okay. So, cold receptors, they have tuning curves, they have temperatures that they respond best to. So the warm receptors respond best to slightly higher than our body temperature. Cold receptors are responding to best to around 25 degrees Celsius, although they're going to respond across a wide range. This graph is a little misleading, it's one of the reasons I like to sort of point this out, is that if you go from 60 degrees Celsius to 50 degrees Celsius, you're going to feel a decrease. Those cold receptors will fire, even though it doesn't look like they have sensitivity, right? If you go from 10 degrees to 20 degrees, the warm receptors will fire and you will detect that increase in temperature. So I like to sort of make sure that everybody kind of understands that. So this range in Fahrenheit is about 86 to 113, or 30 degrees to 45 degrees there. It's sort of a most sensitive, not an absolute range, most sensitive range. Right? So this is a warm fiber. And so what we see is as we go from 30 to 35, we get an increase in firing, and then that increase in firing may be sustained for some period of time, but then will adapt, right? And we no longer feel that increase. So when you walk into an air-conditioned building, right at first you get that sort of blast of cold air, but relatively quickly we adapt and you no longer feel like it's cold in that room. Where you walk, if it's cool outside, you walk into a heated room. When we talk about their sort of best range for warm fibers here, it's sort of how much do they fire in response to that. So this is in that sort of sweet spot. Now it's again just a 5-degree change from 40 to 45, but we get a much more robust firing pattern. And when we're outside that range, 45 to 50, we get a smaller firing pattern. All right, so that's sort of a big understanding. So thermal adaptation happens relatively quickly. And this is the demonstration that we did before class on Tuesday, right? So when we have warm adaptation, not only do the warm fibers stop firing, right, but we get sensitization or an increase in sensitivity in the cold fibers. And vice versa, when we have cold adaptation, cold fibers stop firing and things that, you put your hand in cold water, at first it's really cold and then eventually it doesn't feel as cold as you would think. But in the same light, the warm receptors are becoming sensitized. So in our deal, you put your hands in warm and cold water, right? And initially you got that experience where the warm fibers were firing robustly and the cold fibers firing. So this is really hot water, this is cold water. The longer you keep it in there, the weaker the perception becomes. Then what happened when you put your hands in the middle bowl that was room temperature? It switched, right? The hand that was in the hot water felt cold, and the hand that was in the cold water felt warm. And it's weird because you're looking at the same water, you know it's the same temperature, but you're getting two different perceptions, right? You don't have to do it for 5 minutes. But, and you can see that within 30 seconds or so, it happens very rapidly, right? And so when you put that in there, you get the opposite perception as the sensitization adjusts. All right. So moving on to pain perception. Who can tell me, who wants to share a time in which they were in pain? You what?
I busted my eye open on a rock slide.
You busted your eye on a rock slide, right? And so how did that feel? What can you describe the perceptions? What happened initially?
Initially, I went into shock because I didn't know what was happening, and then it started hurting me.
Yeah, so sometimes we have these intense pain signals that come in, and our brain has to deal with it. And so we may say, like, we go into shock, right? We kind of block those signals until our brain can interpret, here's what just happened, here's an injury, I'm detecting substance P coming in as a pain signal, right? And then we start to have pain perceptions. Okay? Has anyone ever been slicing something with a knife and then you cut your finger, right? And you're like, you realize, you get a pain sensation right away, and then you look at it and it's like, okay, that wasn't too bad. Or, wow, there's blood, this could be really bad, right? So our cognitive interpretation changes, is a top-down influence, and changes our pain perception. It can either lessen it, or it can make it more, or it can increase that pain perception, right? So there's sort of a multimodal nature of pain, that we have these specific sensations coming in with substance P, coming in the pain pathway as bottom-up signals. But there's also an emotional component, right? A cognitive component that can either increase our perception, even though this isn't changing, right? You cut your finger, you're getting the same substance P coming in, unless we activate our natural pain management system, that I'll talk about today, right? But our emotional interpretation of how bad that is can then influence our pain perception. All right, so it's, these are associated with actual tissue damage, the bottom-up signaling, or the potential for tissue damage, or the ramifications of what does this mean, right? And those are the top-down influences, our cognitive interpretation of how bad this is going to be. All right, so some people are not sensitive to pain. Wouldn't that be great?
Couldn't feel pain. That would be great, right? Or would it? Let's meet Steve Pete. Steve, I understand you don't feel pain.
Yes, I was born with a rare genetic condition called congenital insensitivity to pain. Only affects about 40 to 50 of us around the world with it.
Only 40 or 50 people.
So far we've been able to find.
And tell me what it means when you say you don't feel pain.
Pain is used to detect injury. It kind of sends a signal to your brain saying, hey, don't do this anymore. It's an alarm system. So what happens with my condition is we feel what's going on. Like if I were to touch your shoulder, you would feel me touching your shoulder. But if I were to touch your shoulder in a way that's painful, I would feel just the pressure, and the signal of pain would not travel to my brain.
Okay, so you feel everything that I feel, but you just don't feel pain.
Correct.
But that can be dangerous. How did you first find out you had this condition?
Well, what happened was I was teething and I chewed part of my tongue off. So my parents quickly took me to my pediatrician.
Wow. Are you ticklish?
Yes.
Do you itch?
Yes.
Do you like massages?
Yes.
Do you take painkillers?
No.
What about a headache?
No.
What about spicy peppers?
I enjoy them, yeah. I mean, I do sense the burning sensation, but not the painful.
What about intestine pain, like gas pain?
That's something I don't feel, so that kind of ties into one of my biggest fears, which is having like appendicitis or any other type of internal damage that I just don't know about until it's too late.
Is there an upside to this? I'm sure that people often naively hear you don't feel pain and they think, oh man, well, you should become a boxer.
The only upside to it is being that I have had so many injuries during my childhood, as I get older, I won't feel the pain that comes with it. Other than that, really, I just try to live my life normally as everyone else does.
I cannot describe pain to you, just like you can't describe a color to someone who's blind.
Which is where I run into my problem with trying to describe what not feeling pain is like.
Wow. Well, Ben. Well, Steve, thank you very much. This was really, really fascinating.
All right, so very rare condition, but pain is so important, right, that it's highly preserved. right? So only 40 or 50 maybe people in the world have this mutation that allows this thing not to feel pain. Right? All right, so let's talk about the bottom-up signal and how does this get transduced, how do we send signals. So there are actually two pathways for pain. Right? We talked about the limbiskal pathway being the mechanoreceptor pathway up through the dorsal columns of the spinal cord. We also talked about a dedicated thermal pain pathway in the anterior lateral pathway or spinal thalamic pathway. Right? So when we damage our skin cells, our peripheral cells, they release chemicals that both activate our immune system, like prostaglandins, but also activate these free nerve endings to say, hey, there's tissue damage, like histamines, for instance. So histamines and other chemicals like bradykinin can activate those free nerve endings that are also used for to detect warm and cool, can also receive these chemicals, right? And we call those then nociceptive receptors when they're getting pain. All right. So free nerve endings, because free nerve endings can detect pain, these chemical signals, temperature can also be highly linked in with pain. And so if something is hot, it can become painful, right? If something is really cold, right, putting your arm in an ice bath can be painful, associated with pain. So when we're talking about the receptors for temperature, those are the warm and cool fibers. When we're talking about the receptors for the histamines and bradykinins and those other chemicals from tissue damage, that's what we call a nociceptive, right? And when those are activated, they release substance P, a special neurotransmitter that pretty much is only used, that I'm aware of, in the pain pathway, as the incoming pain pathway signal. So pain is such an important perception to us that we dedicate its own neurotransmitter that's not used in any other part of the brain. All right, so with the limbiskal pathway, right, there's a threshold from, like you said, I can touch your shoulder and you feel touch, or I can touch it in a painful way that's going to generate pain, and that painful way is going to be a highly intense pressure, right? A very big pressure signal, right? So if someone comes up and touches you on the shoulder, you're going to feel that touch. It's going to go through the limbiskal pathway up to your contralateral somatosensory cortex, and you're going to say, hey, you touched my right shoulder. But if someone comes along and punches you in the shoulder, and it's a very big, intense pressure signal, that goes up, and not only do you feel, hey, someone just punched me in this part of my body, but there's an emotional pain component associated with that. So how does that happen? Well, it happens at the level of the spinal cord as that signal comes in and forms a synapse, as that mechanoreceptor sensory neuron forms a synapse, and that is going to send its signal on up to the dorsal columns. There are other connections there, and if it's a little signal, if it's a little signal, it just passes up to the touch signal. But if it's a big signal, it can reach a threshold that not only is it going to go up to the limbiskal pathway, but it's also going to activate the anterior lateral pathway, so we get touch and we get substance P release with pain. Does that make sense? It's almost like a gate that it passes through, and if it's big enough signal of pressure, then it's going to trigger pain instead of just touch. Yes?
The anterior lateral pathway, is that the spinal thalamic?
Yes, those are interchangeable. Spinal thalamic and anterior lateral. And limbiskal and the dorsal columns are the same. All right. So, what is a typical pain perception? Have you ever hit your finger with a hammer when you're trying to put a nail in, right? What is your perception of when that happens? Yeah. So when you first hit it, there's an intense like, oh, I missed the nail, ow, that hurts, right? So you get that sharp pain, and then there's a throbbing that comes a little bit later, right? So there's actually two components to that. Right? And so we get that sharp immediate pain, and then we get a sustained pain signal. And that throbbing then helps, is really, again, an alarm system to say, hey, you just crushed your thumb here. Maybe not touch your thumb or use your thumb. I'm going to remind you not to touch that or use that by making it very sensitive and throb and have this sustained painful sensation, right? So the lemniscal pathway initiates that large, sharp pain, and it's through those myelinated, large diameter neurons. And then the spinal thalamic pathway has smaller diameter, myelinated and unmyelinated. That's going to have the emotional component, the sharpness through the myelinated, and then the throbbing through the unmyelinated. So unmyelinated neurons are going to have much slower signal conduction because we're regenerating that signal all the way along the axon instead of having it jump from node to node to node in between the myelin. All right, so we just did that, right? That intense immediate pain is the A beta mechanoreceptor signal, and then the sharp secondary, the dull throbbing pain, sorry. The intense pressure pain comes through both the lemniscal pathway, through the A beta mechanoreceptor, the myelinated, and then along with that, at the same time, both myelinated, right, you get the sharp pain, the immediate pain, the A delta fibers. The C fibers are the unmyelinated fibers that are going to provide that dull throbbing pain that persists after the immediate incident, right? And so together we get the sharp signal and then we get the secondary signal. Yes?
So the intense immediate is associated with the lemniscal, and the sharp secondary is associated with the spinal fluid?
Yes. All right. And these are essentially happening at the same time because they're both minor. Right? All right, so where in the brain do these signals go? So you remember when I talked about the spinal thalamic pathway on Tuesday, it both goes to the somatosensory cortex, but also goes to the cingulate gyrus in order to generate the emotional component associated with pain. So we have activation of S1, of the postcentral gyrus, that helps us localize where on our body is the injury, right? That's gives us the where is it. And then we have limbic system, particularly the anterior cingulate cortex, or ACC, that is associated with negative emotions, and that gives the emotional value of pain. So there's the pain center in the brain we think is involved with the cingulate cortex, although there isn't like a specific necessarily spot per se, it's more distributed across that limbic network, right? Yes?
So what's S2?
S2 is secondary somatosensory. So it's going up to our primary and secondary somatosensory for us to know which place on the body is generating the pain signal, and then it's going to an emotional.
Yes, what is S2? Like what part of the brain?
It's part of the postcentral gyrus.
Okay.
And then there's a whole bunch of other limbic, like I said, this distributed emotional network, like the amygdala. What is the amygdala involved? Emotional value, right? And so now I'm going to have a negative value associated with that hammer that hit my finger, and maybe when I look at the picture that I hung up, I'm going to have sort of a negative emotional value of, yeah, I remember when I really crushed my finger trying to put that picture up, right? And this is also going to influence our decision-making and judgment, so the prefrontal cortex gets activated, and we're going to form memories of that event, and there's a strong emotional component. So, you could tell me probably a lot of memories about when you hurt your eye, right? You remember who you were with, what the day was like, right? What you were wearing, right? And when did this happen?
I was like 8.
You were 8, so over 10 years ago, right? And you still remember all that. I would bet you probably can't remember who you were with or what clothes you were wearing the day before that happened, right? So you form this intense memory, and that's a protective mechanism, right? Because when we're in pain, we want to remember everything that led up to that and never do that again, right? Ideally, we want to prevent it from happening. So the memory formation is a protective mechanism to prevent us from injuring ourselves again. All right, so when we have physically induced pain, right? These areas of the brain, we get S1 and S1 being activated. We get the limbic centers, the prefrontal cortex, the amygdala, memory areas, the cingulate cortex being activated as well. And here we see the anterior cingulate cortex being activated. And the intensity of that activation for low pain and high unpleasantness, when people report that's very unpleasant or that's mildly unpleasant, is directly correlated to brain activity, to the amount of brain activity. So just like we talked about many examples in vision about our perception of vision is because of the increased activity in a particular area, our perception of pain is because of increased activity in the anterior cingulate cortex. Here, we have people under hypnosis that are being told that they are feeling pain in a scanner. And what happens with that, at low pain and then high pain levels, we see more activation in the brain. And the S1 area doesn't become activated in this situation because there is no physical incoming sensation of pain. But under the hypnotic suggestion, the power of suggestion, people actually feel pain because they're activating, self-activating these painful areas of the brain. All right. So, in addition to these painful areas being able to be activated by pain itself, we can internally, not just with hypnosis, but you can activate these areas, and we call that empathy, right? I feel your pain, right? If you see somebody in pain, it triggers the pain perception in your brain. Not as much as if you were actually experiencing it, right? But this is what we said, this is what we talk about when we talk about empathy. Okay? And studies have been done looking at having people look at strangers with pain, and that generates less empathy than a significant other that's experiencing pain. Someone that's close to a partner that's experiencing pain. It generates more empathy, more brain activity in these areas. It's easier to act. All right, so I'm going to talk about the thermal grill, but this is a good sort of demonstration of it.
When it comes to illusions, optical illusions get all the attention, but the whole body you have can be fooled and can fool the brain. One of my favorite physical illusions is the thermal grill illusion, and you can do it right at home. I have some hot dog halves in an ice bath. I also have warm hot dog halves. Now what I'm going to do is marry the halves together so that they alternate. Warm, cool. Warm, cool. When I'm done, I will have a torture device, but not one that hurts your body, one that hurts your mind.
I'm not suggesting that you go back to your room and torture your roommate by making a thermal grill. Not it. All right.
Rosanna Pansino.
Hello, Michael.
Welcome to Minefield. Rosanna Pansino is the host of the YouTube cooking show Dirty Numbers.
Green cake.
So So I thought she would be the perfect candidate to try out our hot dog illusion.
Yeah.
Now, you didn't hear or see anything I just did, right? No. Good. All right. Well, you are in for a treat. What I want you to do is take the bottom of your forearm and place it skin showing, okay, right onto these hot dogs. Oh. What'd you feel? Ouch. But now touch them individually.
They hurt. Cold, warm, cold, warm, cold, warm.
But none of them is as hot as they all felt together. So what's going on?
I don't know. Magic?
Can I try?
What's going on over here? Yeah, do
It's my
it.
show. Oh yeah. What we've built here is a version of the thermal grill illusion. And for reasons that are still being debated, this can cause a sensation of pain. Maybe the sensors we have, specific to hot and cold, are both also specific to extreme pain, and getting them to fire right together makes the body think, whoa, 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 if they're both firing that near to each other, that means get away.
Red alert.
Red alert.
That's alarming.
Yeah. So what I'm really trying to say is this is a great way to hurt someone without there ever being a mark or any actual damage.
It's pretty sneaky.
Do try this at home.
All right, maybe. This actually is something that people have done a lot of research on to sort of understand, and we do understand why we get a painful sensation when neither stimulus by itself is painful. And so most thermal grills, scientific thermal grills, are going to have these metal bars, right, that are hot or cold. And as he mentioned, they're not, the temperature is not sufficient to cause you to feel pain if it's just if all of them are warm or all of them are cold. But when, so over here, right? So we activate the cool receptor, that goes up, we get a cool sensation, right? If we activate cool and warm at the same time, our brain reroutes that signal out of the temperature and into the pain area. And so here we see where people have just touched cool, and it's activated just the thermal areas, right? The insular cortex is one area that responds to temperature here. And here's just warm pattern of brain activity, right? If we make it so cold that it's painful, it's all cold but painful, so we have noxious painful cold, we now turn on intense activity in the anterior cingulate, and the anterior cingulate here, intense activity in the insular cortex, and we get activity in the ACC, and so that's a cold pain stimulus. We make it extremely hot, we get a hot pain stimulus, right? Now, when we take these two and alternate them, it stimulates, it gets rerouted and stimulates that anterior cingulate cortex and generates that painful sensation. So anytime that our brain, we talked about pain with the vision system when we talked about light adaptation, right? When you turned on the floodlights to light adapt the next period, it was painful, right? And that painful sensation is the bleaching of all of those rods that built up all that photopigment, and it's sending an intense signal to your vision. And anytime our brain gets overwhelmed with incoming signals, it turns on the pain system because that's our alarm. Stop doing it. That's the motivator to stop doing it, right? And so that's what's happening here with the thermal illusion. We can also detect internal pain, and that was one of the fears of the congenitally pain insensitive individual that was talking. Was it Steve? That was talking was that he would have an internal injury like appendicitis and not know that he has to go to the hospital, right? You get appendicitis or you get kidney stones, you have this internal pain, right? And you seek medical help, right? But if you can't detect that, you wouldn't know until it ruptured and it would be too late at that point, right? So when we have internal pain, that signal has to get to the brain. And for that signal to get to the brain, it has to go in the spinal cord at some dermatome level. And the brain then associates that signal, even though it's coming from our heart muscle, it associates that pain with the dermatome where it comes in. So what are the symptoms of a heart attack? What have you heard?
Chest pain.
Tightness of the chest pain, and usually a shooting pain down the left arm, right? That's because the heart is coming in through the dermatome that's also the dermatome for your left arm, right? So your left arm isn't physically hurt, but our brain's interpreting, hey, there's pain activity coming in that dermatome. That's normally the skin of my left arm. So this is called referred pain, where it gets referred to that area. Sometimes also like the esophagus. So if you have like stomach pain, sometimes that feels like it's a burning sensation in your skin there because it's coming in through that same dermatome. Right? So we have esophageal pain. We can have prostate pain that's coming in through that lower dermatome. If you have kidney stones or ureter pain, then that's going to be in the side skin area. And it feels like that part of the body is in pain because we're not used to experiencing signals coming from inside our body. Carol?
Would it be the same reason why some, like Western, or not Western, but Eastern medicine would believe like different parts of the body are connected? Like, in
Sure. Yeah. And we'll talk about acupuncture and how that could maybe eliminate pain. All right. So, cognitive influences on pain. Our expectation about pain, about if something's going to be painful, can actually trigger those pain areas. So, just like we saw that you could have empathy and feel pain for someone else by internally activating your pain pathways, right? You internally have top-down influences on how much activity might happen in those pain regions, right? And so we can have things like a placebo effect, where I tell you I'm giving you pain medication, and because you believe that, you cognitively turn down the perception of pain, even though it's a placebo and not a real pain medication. And that's a real effect that happens. And so, yeah, let's stop. Other ways that we can cognitively influence pain. Attention plays a role. So when we talk about attention in the vision system, what did attention do to the visual sensations? Enhance it, increase them, right? So if we're attending to pain, we're actually increasing our perceptions of it. If we can shift our attention and distract the brain from those painful sensations, then we can reduce those, right? And this has been applied clinically. Patients that have burns on their body, that's a highly painful injury. And it's made worse by the fact that to keep those areas clean, you have to constantly change the bandages, right, to prevent infection. And just touching those areas and doing that can be very painful for the patients. And so they found that the more they can immerse them in a virtual reality world with goggles while they're changing the bandages, it actually reduces their pain perception by trying to engage them in an activity that diverts their attention away from the incoming pain signals that are coming in. Yes?
So is this like why walking it off can sometimes actually help and make it not as bad?
Yeah. It's part of the shifting of attention or distraction, right? The activation of your emotional system can either enhance or could decrease pain, right? So, if I'm having a really bad day and I hit my finger with the hammer on that day, it's going to be worse pain perception than if I'm having a great day and I'm really happy and everything's going well, and I hit my hand with my finger. My pain perception may not be as bad based on my emotional tone in my body. And we talked about how, or we will talk about how smells are directly linked into emotions, right? So having positive smells and smells that make us feel good can actually decrease our pain perception. And then finally, there's individual differences, right? Some people are really sensitive to painful stimuli. Other people can tolerate a lot of painful stimuli. And our experience can change our individual sensitivity, right? So people, for instance, if like athletes that have to soak in an ice bath repeatedly, right? The first time you do that, it can be very painful, but as experience builds up, it becomes less and less painful each time until it's something that really isn't that painful, even though the physical stimulus has not changed from the first experience to the last. Cognitively, you've learned to reroute those pathways and not interpret them as painful. All right, so how does this happen? How do we cognitively change these signals? And it turns out that we have what was coined by Melzack and Paul, I forget the other guy's name. Yes,
so like after surgery, I have a numb spot on my knee. Do I still like technically experience pain there and I just don't perceive it, or how does that work?
I don't know, but I would guess that either the injury or the surgery has like either damaged or cut those neurons that are sensing for that area, and so you're not getting an incoming signal from that area, is what I would guess happens there, as opposed to a cognitive influence. Cognitive influence wouldn't necessarily be for a specific spot on your body. Right? All right, so anyway, the researchers coined this gate control theory, and it's the theory of, it's not really a theory, it was when they first were describing it, it's known now, it's a fact, that we have an ability to turn up or turn down our pain sensitivity through endorphins in our body, our natural pain management system. All right, so we have a descending pathway. The blue pathway is the spinothalamic pathway. Red pathway is our descending here, pain management pathway, and it comes from two areas. The periaqueductal gray area communicates to the raphe nucleus, which then sends a signal down to the level of the spinal cord where the incoming pain is. So these areas are activated in response to painful stimulation. And they send their descending input down just to the area of the spinal cord where the incoming pain sensations are coming. That's sort of the beauty of this system, is that it's not global, it's very specific. And it's so specific that we can turn down the pain here for my thumb that I now smashed, my right thumb, and it doesn't affect my left thumb on the other side of the spinal cord. I've maintained my pain sensitivity here, even though I've turned it down at the site of injury. All right, so how's this work? When the PAG and the raphe send these signals down, they form a heteroreceptor, so an axon-to-axon receptor on the incoming pain signals releasing substance P in the spinal cord. And that endorphin signal turns down the release, inhibits the release of substance P. So the action potentials from the site of injury are continuing to come in. They're just not releasing the same amount of substance P because of the natural pain management system. Does that make sense? All right. So this is all happening in what we call the dorsal horn, that gray matter of cells and connections here in the dorsal horn, an area also called the substantia gelatinosa. and this is where this whole gate circuitry is happening. The neuron that's projecting to the brain and through the spinal thalamic pathway, in this model, we're going to call that the T cell or the transmission cell. It's the output of pain, right? Traveling up through the spinal thalamic anterior lateral path.
It's the what?
Yeah, so the incoming pain is forming a synapse right here, and then it's sending its signal up the spinal thalamic pathway, and we're going to call that neuron in this model the transmission cell. It's transmitting the pain signal to the brain.
The neuron that travels up the spinal cord.
Yes. All right, so this is what our model looks like. We have, this is one image of it. I'm going to use a different non-color coded one. But we have both large diameter limnoscal pathway neurons that can trigger the large signal here, right, triggers that gate that's going to activate pain and not just be touch. And we have our dedicated pain neurons coming in that's going to also activate that transmission. And then we have some processing that's going to happen in the substantia gelatinous of the SG. All right, so this is the model that I like. We have the PAG is our central control, and we have an inhibitory neuron in the substantia gelatinosa, and we have an excitatory neuron. If the inhibitory neuron is stimulated, it's going to inhibit the transmission cell, which turns down the pain signals going to our brain. All right? We also have the ability to open the gate and be more sensitive to pain, be highly sensitive to pain by stimulating an excitatory neuron. So, and so we have limnoscal fibers, and sort of just defining everything. Spinal thalamic fibers and transmission cell. All right. So, when we have high intensity limnoscal activity punched in the arm, right, that's going to pass through that gate and trigger the transmission cell when we get pain. Okay? However, so what do you do after you smash your finger with a hammer? Wave it, shake it, maybe gently rub it, maybe run it under water, right? What happens if they, have you ever had a pet that had an injury? What do? They lick it, right? They generally lick it or groom the area that's injured. That's providing a low level of mechanosensor activity. Running your thumb underwater is gently stimulating that, and that's a mechanism to close the gate. Close the gate. Right? You hit your finger and you put it in your mouth and suck on it. That's, all of those things are low levels. They close the gate. Right? If we have activity through our dedicated pain system, right, we're going to get a pain output, right, every time for that. So low intensity, and then even if we then have low intensity pain, we can activate, open this gate, particularly after we've injured ourselves. So you hit your thumb with a hammer, right? And so now we say my thumb is very sensitive. Even low stimulation is going to activate that system. All right. So we have incoming pain, right? So what do? You're going to take some opioid agonist, some drug, that's going to act like enkephalins in our endorphins in our body and bind and close that gate. So pain drugs, pain management drugs, are in general acting in the spinal cord to close the gate, but they don't just act at the site of injury, they act globally, right? They're circulating, they act globally, and not just in our spinal cord, but they also can act in our brain and produce effects in our brain as well. So that's how sort of pain management drugs close the gate. by acting through our natural pain management system. Again, the difference is when our natural pain management system is activated, it only releases, it only triggers this closing of the gate where the pain is coming in, and it doesn't even affect the other side of the spinal cord. It's very site specific, as opposed to drugs, which are global. All right, when we can have, as I mentioned, low vibration, usually stimulation, can help close the gate by acting through this same sort of pathway. Not as strong as taking an opioid drug. Opioid drugs are very strong. They bind and really trigger and activate this strongly, but there's this ability to reduce pain through this light stimulation. Right? And so this is how we think things like transcutaneous electrical stimulation, where they stimulate an area of the body that's in pain with mild currents. It's mimicking, it's sort of triggering this pathway in an artificial way. It's also how we think that acupuncture can work, is by putting those needles in certain places that it's stimulating the system to release endorphins and close that gate. And then finally, we have our natural pain management system that can be activated in response to pain, but we can also cognitively harness that and learn to control that and shut that down to close the gate. And so we have things like stress-induced analgesia, right? So someone that's in a very stressful situation, so a soldier gets shot in a battlefield, and they're still able to help their other soldiers get out of there and fight, and then when the battle's over, they're in intense pain so much that they're incapacitated. That pain was there before, but was being blocked through the stress-induced activation of this central sort of control. And you can think about this like athletes that are in an important game, and they injure themselves, and they may continue to perform in that game until the game's over, and then the pain really sets in. Right? This is where the placebo effect I talked about comes in, where we can actually mentally sort of block that pain by self-activating this system. And this is also the way that we can have sort of socio-cultural effects on pain, right? Can also harness the ability to trigger this system. So, if you injure yourself and all your friends are like, oh, it's not that bad, shake it off, and right, we can have the influence of other people that can then cause that area to get triggered, and then we actually feel less pain in response to it. Do you have a question?
Like when pain is so bad, your brain will literally black out. And what is that your brain trying to so you don't remember that because it was so traumatic to the brain, or is it because it's overstimulated with?
I think it's overstimulated, right? And so you have this intense stimulation that's coming in, triggering all these brain activations, but then you have cognitive interpretation of how bad this is. And so the brain just kind of shuts off, if you will, right? All right, so in addition to cognitively being able to close the gate, we can cognitively open the gate as well. So like I said, if you're expecting to feel pain, right, then you can have the opposite of a placebo effect. A placebo effect would be reducing pain. There's also an effect called a nocebo effect that is triggering this pain pathway mentally without there being a physical pain stimulus. Does that sound, y'all believing? Does that sound weird? No? Yes. So again, we already kind of talked about this when we talked about empathy, right? But you don't really experience that pain too much. You experience sort of the emotional component, but not really a painful sensation, right?
Perhaps the most surprising way that the brain and pain interact can be demonstrated by the nocebo effect. Have you ever heard of the placebo effect? It's like when a fake pain pill actually cures a person's pain because they have a positive expectation it will work. Well, today, we're demonstrating the exact opposite. If a subject expects they're going to experience something unpleasant, like pain, will they feel it, even if it actually exists only in their mind? We've told our subject that she's participating in a study to test a non-invasive bone density scanner. But actually, it's a totally fake machine that we built from a desk lamp, an air compressor, and the kind of $10 laser pointer you might tease your cat with. It doesn't cause physical pain, or for that matter, physical sensation of any kind.
It doesn't hurt at all. You guys, this doesn't work.
But will the expectation alone make our subject think she's feeling real pain?
Come on in here. Just go ahead, take a seat right there. And then when you're ready to drive, just let us know and we'll dismiss you, okay? Thank you.
First, we have to make our subject expect to experience pain. And to do that, our actors are going to scare her a little. Sorry, Jessica, this is for science.
So are you already done?
Yeah, I just, need a minute. I'll be good to go.
What'd you do?
It's like turning a laser. It tests bone density.
Did it hurt?
Yeah.
By the look on her face, it appears we have successfully primed our subject for what's to come.
Jessica, we're ready for you.
The question is, when put to the test, will she actually feel pain when there is really none there?
This is Jessica. Hi, Jessica. Come on in. Do you have a seat?
Everything in this room, the medical equipment, the hospital supplies, even the demeanor of our fake nurse, is designed to play on Jessica's mind, to psychologically induce the anticipation of pain.
We're testing out some equipment. It's not invasive. We need to measure the side effects and patient reaction. And I want you to be really descriptive about what you're feeling and pay close attention to the pain that you feel and how it grows.
Notice how we are suggesting that she will feel pain, further raising her expectations.
I'm going to give you a ball to squeeze for pain management, okay?
And anytime you want to stop, it stops right away.
Okay.
Okay?
Now remember, this is just a laser pointer. It's just this, right?
Definitely warm and like tingly.
After only about 7 seconds, she's already feeling a physical sensation on her skin where there is none. Keep in mind, we tested our fake bone scanner, and the light emits zero heat or feeling of any kind.
Yeah, no, it doesn't feel that great.
Turn it off
No, it's okay.
for 30 seconds.
It's really like stinging.
A sting?
A sting and like really, really hot.
Now it's hot for 45 seconds.
Yeah, it doesn't, it's,
Okay, I'm going to turn it on.
thanks.
You described warm turning to hot.
It was like warm and then that like heat grew into more like a sting.
On this pain scale, would you point to the amount of pain you were feeling?
Between a 6 and a 7.
According to the pain assessment scale, she experienced significant pain.
This is completely up to you, but we can move to level 2, which is slightly more intense.
How many more levels are there?
There's just 5.
There's 5 levels.
There are 5, but again, you're in the driver's seat.
Yeah, sure. Let's do it.
Here's another test of our nocebo. Will she feel an increase in her level of pain if she expects to?
You ready?
Keep in mind, level 2 is fake. We're not doing anything different than before, meaning nothing is happening to her.
So yeah, it started off higher than the last time, I think. It's definitely like already stinging.
Immediately, she reports increased pain on level 2.
It's 15 seconds.
It feels really, really, really hot and like penetrating.
30 seconds.
I don't know, like half an inch, like an inch. Yeah, it is. Very hot, like burning. Like my whole arm is like on fire.
It's stop at any time.
You want to call it? Do you need a tissue?
Yeah, thank you.
Could you rate for me how you felt at level 2?
Like 9.5.
The power of suggestion was so strong, our nocebo caused our subject to think she felt almost the worst pain imaginable.
So, one thing I want to point out here, I mean, it's funny, but I mean, it's a little dramatic. She's not just thinking that she's feeling pain. She's having a physiological reaction to something that's not occurring, right? The brain is so powerful, it's triggering that anterior cingulate area without any bottom-up signaling coming in to a level that's making her cry, right? It's that painful. Yes, yes.
Does this clip show the debriefing of the conversation?
Yeah.
Other subjects felt different imaginary sensations.
The muscles are kind of burning a little bit.
How did that feel?
That was like a 7. Actually, it's tingling a lot more now than it was before.
I was surprised at the intense reaction some subjects had to a feeling that was created only in their minds.
We're going to stop it now. That was 45 seconds. Describe for me the sensations that you were having.
It felt like a little prickle, like when you get goosebumps.
What about our original subject, who experienced a severe 9.5 on the pain scale? How will she feel when she learns it was all in her head?
I want to debrief you on everything that we're up to today. So this is a psychology program, and this equipment is not doing anything to you. This is just a machine that makes noise, and that's just a laser pointer on a lamp.
For real.
For real. We're never in danger.
We can do anything to
This is an investigation in pain anticipation.
Yeah, that worked.
I was so scared. I was so close to like going to like just say, you know what, I changed my mind. I was so close to leaving.
I mean, you did say that you felt a prickle. How do you feel about that?
Whether it was really I did get goosebumps or I was nervous, which is why I felt it, I know as a person, like if I think there's gonna be pain, I'm gonna feel something.
I do still feel like kind of like a burning sensation on my arm.
Really?
Yeah.
The power of suggestion is so strong that this subject continued to imagine a physical sensation even after learning it wasn't real.
The name for the effect is the nocebo effect. It's a negative effect caused by nothing but the mind.
It makes perfect sense, you know, the power of suggestion. I'm shaky just thinking about it.
Alright, so, you know, even after people are told nothing happens to them, they still feel, their brain can still create that painful sensation, right? Are there other times that we internally activate, turn on this pain system without there being physical pain? Can you think of it anytime?
Like with anxiety.
Yeah, with anxiety, right? Or with, we can generate a pain perception from a situation, a contextual situation that's not generating physical pain sensations, right? And so there's research study that looked at social exclusion, right? And how social exclusion can induce painful emotions in our brain without there being bottom-up signaling coming in, right? And so here, what they're showing is the same patterns of activation for the social exclusion test. So this is her feelings rating, and this is on day 1. And what they did was they had some of the people got a placebo, and so there was no effect, a placebo effect here, right? Their pain ratings stayed the same across the 21 days they did this. But another group got acetaminophen, an actual pain medication, right? Remember, they're not having any incoming pain, they're just having the social exclusion test that they're doing is making them feel that, making them have that hurt feeling, right? And the hurt feelings are coming from activity in the same anterior cingulate and insular cortex being activated, even though there's not a physical painful stimulus. And the actions of acetaminophen, it doesn't act like an opioid on the peripheral system. It acts in our brain to turn down these areas. And so it was actually successful in reducing the hurt feelings by decreasing this activity. Yes?
So, like, say somebody died. If you took ibuprofen, it would help you to not
Feel as much pain. Yeah. That's what this says, right? And so here, we see this is quantifying the brain activity. Under the placebo, there was more brain activity in those areas in the anterior cingulate and insular cortex. And on day 21, after taking 21 days of acetaminophen, there was decreases in that brain activity that corresponded with this. So again, activity in our brain creates our perceptions. It creates our conscious perceptions. And when we have areas of the brain associated with pain that get activated either by real pain or by negative situations like the social exclusion test, we feel our perception is of pain. And if we can turn down those areas in our brain, right, and shut them off here, then our hurt feelings, our painfulness goes down. Right? So, if your roommate's boyfriend or girlfriend breaks up with them and they're having a rough time, I think they should take an Advil, right, or an ibuprofen. All right, we're going to get out of here early today. I know I've been jamming a lot of stuff into these lectures. I'm going to do a 35-slide lecture instead of a 65-slide lecture today, and give you an early start to your weekend, okay? Don't forget to do your lab before I see you.